Our next speaker is Bill Kapogiannis, who is going to present work on the prevalence of and progression to abnormal non-invasive markers of liver disease using APRI and FIB-4 in US HIV-infected youth. Welcome.
Thank you, Marina and Marian, and to the conveners. Thank you for inviting me to talk to everyone about the prevalence of and progression to abnormal non-invasive markers of liver disease, APRI and FIB-4 among US HIV-infected youth. A little bit on the background, which we may have already heard some of. HIV infection may contribute to liver disease even without viral hepatitis co-infection. There's also the potential for ART to also contribute to liver problems. And the non-invasive surrogate markers that the FIB-4 and APRI have been investigated and validated in HIV and Hep C co-infected adults, but have been less studied in children. The FIB-4 index includes age, AST, ALT, and platelet count, and calculated there as is shown, with the relevant clinical thresholds here, the 1.5 and 3.25, with suggestive of mild to moderate and potentially advanced fibrosis. And then the APRI is the AST to platelet ratio index and includes AST, its upper limit of normal, and platelet count, and is calculated as follows, with the relevant clinical thresholds there for mild to moderate and advanced of 0.5 and greater than 1.5 respectively. So the objectives of the study were to determine how FIB-4 and APRI measures compared between HIV-infected and uninfected youth aged 15 to 20 years, and then among focusing on infected youth to determine what are the factors that may influence any differences, and finally to characterize how these effects behave over time in HIV-infected individuals. A little bit about the two main cohorts that are part of this larger cohort study. Reaching for Excellence in Adolescent Care and Health, the REACH study was a prospective observational HIV-infected and uninfected youth cohort with sequential behavioral and biomedical assessments and specimen collections from March of '96 to November of '99. The PACTG 219-219C study was a prospective multi-center cohort study of HIV and its treatment in infected infants, children, and adolescents with serial biomedical assessments from April '93 to May of 2007. And the FIB-4 and APRI measures were evaluated in HIV mono-infected youth and HIV uninfected youth, ages 15 to 20, as I mentioned. So these measures were evaluated first in a cross-sectional comparison between HIV-infected and uninfected youth based on a single visit, and then longitudinally focusing again on only on the HIV-infected youth who had at least 2 visits or more. And among those with low baseline scores, we estimated and compared incidence rates of progression to higher scores during follow-up. And then we also used repeated measures, mixed effect linear regression modeling to estimate longitudinal trends in log transformed scores, adjusting for age, gender, exposure category, and BMI Z-score. So, busy slide, but the main highlights I will go over here in the participant characteristics by the sub-cohorts here. The age at which LFTs were abstracted, the median was lower among the perinatals in the 219C study. The follow-up overall for the whole cohort was about 2 years. There were proportionally more females in the REACH uninfected and behaviorally infected cohorts who were also on the heavier side, as you will note there. And then notably the perinatals in 219C had a larger proportion, 60% there, who were on a PI-based heart regimen that then is reflected in their better HIV RNA and T cell counts. So in the cross-sectional analysis, looking at the distribution of these markers and the relevant clinical thresholds, we look at here on the left, FIB-4, we did not have enough samples in the clinically relevant greater than 1.45 or more cutoff to have any significance. However, in the APRI, you will note that there were statistically significantly more HIV-infected youth who had the APRI of greater than 0.5, which is indicative or suggestive of potential mild to moderate distillate or more, or worse liver disease. And that was also similar if you split them up by subcohort. So, and that's also, I should note that that's comparable to the pediatric study, the limited pediatric studies that are out there. The univariate analysis for APRI greater than 0.5 then indicated that having male gender, being HIV infected, having a low BMI Z-score, CD4 count of under 350, and a viral load that was detectable above 400, and not on any ART as significant predictors in the adjusted models, among the entire sample being, again, HIV infected and male, and having a low BMI Z-score independently predicted the APRI of greater than 0.5. Among focusing on the HIV infected participants, the male gender, low CD4 count, and detectable viral load were independent predictors of APRI greater than 0.5. So switching gears on the longitudinal analysis, looking at the rates of APRI and FIB-4 progression, again, comparable to pediatric studies. You can see the number with progression greater than 0.5 of APRI and greater than 1.5, 176 and then 39 respectively there. And then the incidence rates, 7.5 and 1.4 per person, per 100 person years respectively. The FIB-4 is kind of uncharted territory, and you can see the rates there were from 1.6 to 0.3 in the most severe. On evaluation of progression rates of APRI and FIB-4 by cohort subgroup, there were no statistically significant associations found. However, by baseline CD4 count across all of the clinically relevant thresholds for both APRI and FIB-4, a CD4 count of under 350 had a incidence rate ratio of anywhere from 2 to 8.64 greater. So on evaluation of progression rates of these markers by baseline HIV viral load, again, there were no statistically significant associations. Switching gears finally to the repeated measures analysis, the mean log APRI score, we noted a modest but statistically significant 2% increase per year among only the perinatals across the 15 to 20 year age group. And then again, male gender, low CD4, detectable viral load, and not being on ART had consistently higher APRI scores over time. Similarly for FIB-4, and a little bit more impressively with the slope 6% increase per year over that same time period, and in both, this time, behavioral and perinatal. Again, the same covariates, the male gender, CD4 of under 350, detectable viral load, and not being on ART were consistently higher FIB-4 scores over time. So the limitations of the study, no liver biopsy was available. FIB-4 experience is limited to adults, and you'll note that we tried to keep this, and that's one of the reasons we're at 15 to 20-year-old in terms of the cohort, because of the age being a significant piece of the formula. FIB-4 and APRI depend on platelet counts, which in general are not as affected in this younger population who don't have cirrhotic livers and thrombocytopenia, so thus the scores may potentially underestimate fibrosis severity. And then the cohort and age effects of the data abstraction were adjusted for, but we may still have residual confounding from unmeasured confounders. So conclusions. The mean APRI and FIB-4 scores were higher among the infected youth and remained so after adjustments. Among HIV-infected youth, progression to values suggestive of subclinical fibrosis or worse was common. The incidence rates for APRI were comparable to pediatric studies in younger children, and then lower baseline CD4 counts were predictive of higher incidence rate ratios for both APRI and FIB-4. And then finally, the differences in score trajectories over time had APRI with significantly increased by 2% per year among perinatally infected only, whereas FIB-4 significantly increased by 6% per year among all HIV-infected youth. And then male gender, low CD4 count, detectable viral load, and not being on ART had consistently higher scores, both APRI and FIB-4 over time. Implications. So we're trying to do, at this point, a validation analysis between FIB-4 and APRI for this age group using clinical disease staging and progression, and so stay tuned on that. And more research is needed on non-invasive markers in youth, particularly among the aging up perinatally infected adolescents. Need to look at liver stiffness assessments and transient elastography, novel biochemical markers, and then also validation with biopsy. I'd like to acknowledge our funders, the NICHD and NIAID groups, and our collaborators in REACH, Impact, as well as at the NICHD and Harvard School of Public Health and Quest Labs. Thank you, and I'll take questions.
Thank you very much. This is now open for discussion.
I have a question. Well, there's a number of interesting things, I guess, that were raised by the different analyses you did. One of the thoughts I wondered about is this association, kind of counterintuitive, between BMI and APRI scores, and where people with lower BMI tended to have worsened scores. Do you have any speculation on why that might be the case in this population?
So it's interesting, right? You're right on target. I mean, you would think the heavier people would have it, but I think potentially, these were perinatally infected adolescents, and maybe were thinner, more disease severity in general. It's interesting. I'm not sure why.
I mean, one of the things I wondered about would be the actual antiretroviral regimens, because of the time frame for many of these exposures was from the early 90s through 2007, whether metabolic toxicities, for example, from early stavudine use or something may have been related. Did you look at antiretroviral regimens?
Yes, we did. I didn't talk about that in the analysis, but we did look at DDI and D4T use as well, and we did not find any significant associations that held out in multivariable analysis.
I think that's David Isaac, but I'm not sure. It's microphone 3.
From Melbourne. The APRI is actually contained within the FIB-4. So I think, and when you're looking at such young people where the only other elements of the FIB-4 are age over the square root of the ALT, you're kind of looking at a new marker, which is 1 on the square root of the ALT. So I think you want to be a little bit careful making too many sort of inferences about the difference between what you found in terms of APRI predicting something versus FIB-4 predicting something. I mean, maybe you're finding something novel about a new marker, which is 1 on the square root of the ALT.
Good point. I mean, I think that's, yes.
And did you exclude, if you're only looking at liver disease, did you exclude platelets under 20,000 and AST/ALT greater than 10 times or 5 times upper limit of normal? How did you exclude acute liver disease and thrombocytopenia due to non-portal hypertension, which is what the marker was designed to look at?
Yeah, we did exclude acute liver disease presentations. I don't know in terms of this, if we used specific cutoffs, but I think that we did in fact exclude.
Do any of our esteemed panel have a question? Oh, thank you, Christina.
Yeah, I have a question about platelets, because you said that not being on antiretrovirals was associated with a higher index. And I was wondering about, I mean, in this huge number, probably you don't know, but I was wondering if you have looked at the level of platelets in those without treatment, and if this changed after treatment.
We did look at what was potentially driving the differences in terms of the transaminases and the platelets, and it turned out that was one of the reasons I pointed it out, that we don't see this in the pediatric population as much with big cirrhotic livers. The platelets were not at all a factor. I mean, there weren't very significant differences, whereas the transaminases seem to be driving these.
Okay, thanks.
So I still have a question.
Yes.
You've excluded the indeterminate range, and Christina, you excluded the no fibrosis range, and Christina excluded the indeterminate range. So I'd like you both to comment on that.
Yeah, actually, we found an association also with the middle FIB-4, let's say. So there's an increasing trend, of association from those who had a very low FIB-4, who still had event, even if the incidence rate was very low, was 0.5 for 1,000, but they still had event, liver-related event. But this percentage really increased even in those with the FIB-4 that was not cirrhosis, but it was indeterminate.
And did you see any change in those with no liver disease, less than 0.5 or less than 1.5 FIB-4?
No, we did not.
Probably
Do you have a question, Mark, or you're just looking interested?
I might ask, have you looked at the commercially available assays? And the reason I ask that is that, as was pointed out, the platelet count is really a big factor in APRI and FIB-4, and the commercially available assays do not use platelet count. And some have suggested that maybe a better assessment of this population. Have you had a chance to look at that using either of the commercially available assays?
We have not, no. That's a good point, Mark.
And I guess, and just following up on that, have you started to look at FibroScan in this population? Because I think ultimately it would be really interesting to have some other.
I mean, I think that this is an area of more investigation that needs to be done. We have not personally, and our group has not, but I know that there are other pediatric investigators. I think there's an international group that's looking at some of these parameters.
Do you know the cause of the liver disease?
So, I mean, the one sort of question here is it HIV, and is it direct, from, toxicity to the liver from the HIV virus? The piece about the drugs, we didn't find any association. We do have a pretty large N, but I suppose, there could be some relationship there that we may not be catching.
Do you know viral hepatitis status?
Yeah, so as part of the selection criteria in the study, we specifically excluded known viral hepatitis within, so A, B, C, but again, the design of the cohort is limited in that, they didn't have regular intervals where they assessed with rigorous measures, incident cases.
It's just one last point. It just seems that you have a very old, historically HIV cohort. So the antiretroviral therapy changed in the 90s, and maybe if you took the newer, your subjects with newer heart, you'd see a different result. Have you subcategorized that way?
So. No, I have not. So we could certainly do that. I think that would be very good to do.
I think Jürgen,
Jürgen's
out there, I see.
Go ahead.
So thank you for your presentation. I think it's very interesting because we're all wondering, obviously, in the absence of viral hepatitis, does HIV cause something to the liver which over time could be clinically significant? There have been studies in the field which, though, suggest that there is a correlation with viremia. And if I understand your data correctly, there was no association with level of viremia and your FIB-4 score. So that does, sort of makes it a little less likely that there is a direct association between HIV and what you're seeing. And so I think then the big next question is it really more reflecting drug toxicity rather than anything else? And I think that's why we sort of, may need other markers than the ones used to sort of get a little better image of what is really driving this. Is this really more drug toxicity, or is it really an HIV effect? But then other data would suggest that then you would see something with relation to viral load level.
So, very good point. I mean, I think that I was being very rigorous, trying to be rigorous in the definition of statistical significance. That it was marginally significant, but it was at the level of 0.5 something, 0.05 something. And so, sample size, again, may be an issue and was playing a role.
And if I can answer to Jürgen, also in our cohort, there was no association, but it was the current viral load in patient that started CART. So the idea is to look at cumulative viral load. I think that the exposure exposure to HIV, the length of time that you have been exposed, and the level of HIV RNA that you are exposed to that could play a role, not just the single HIV RNA.
Yeah, a cumulative measure would be really helpful. That's a great idea.
Yeah, and adolescents are fantastic. I mean, those who are born with HIV are the perfect settings to study the length of HIV exposure.
Well, it's perfectly known, yeah. Okay, thank you very much. I think obviously brought up a lot of discussion and a very important area to pursue, I think.